All right, let's dive right into this explainer. Today, we're taking a close look at the rapidly evolving and, frankly, incredibly complex 2025 medical landscape of Duchenne Muscular Dystrophy, or DMD. This is a disease that has completely shifted from being purely a subject of palliative care to sitting right there on the absolute bleeding edge of biomedical engineering.
Now, to really wrap our heads around the immense stakes here, just take a look at this staggering figure, $3.2 million. Yep, that is the cost for a single dose of the gene therapy Elevidys. And as you can imagine, a price tag like that raises massive global equity concerns. It literally turns a scientific breakthrough into a profound socioeconomic challenge.
And it's crucial to remember that this disease is far from some isolated anomaly. We're talking about the most common childhood muscular dystrophy, affecting roughly 1 in 5,000 live male births globally. So, while it's classified as a rare disease, cumulatively it impacts a vast number of families all around the world.
So here's how we're breaking down this dense medical data today. 1. The missing shock absorber. 2. The 5 pillars of treatment. 3. Gene therapy and CRISPR. 4. The multidisciplinary care base. And finally, 5. The future of access.
Starting things off with Section 1, the missing shock absorber. Let's look at the molecular pathogenesis of DMD.
So, why does a single genetic defect cause such devastating physical decline? Well, the core issue lies in a truly massive 2.4 megabase gene sitting right there on the X chromosome. This giant gene encodes a protein called dystrophin, which essentially acts as a molecular shock absorber for our muscles. Every single time you move, dystrophin is what protects your muscle cell membranes from contraction-induced injury.
The problem, of course, is what happens when that shock absorber is missing. It triggers a catastrophic biological cascade. Step 1, the muscle membrane actually destabilizes and tears, which causes intracellular calcium to leak. Step 2, that calcium hyperactivates these destructive muscle-eating enzymes called proteases and HDACs. And step 3, this kicks off chronic inflammation, permanently replacing healthy muscle tissue with fat and fibrotic scar tissue.
Now, because the DMD gene is just so remarkably huge, it spontaneously mutates in a few different ways. About 65% are deletions, 10% are duplications, and 25% are point mutations. And this is exactly why modern diagnostic workflows rely so heavily on advanced genetic testing, like next-generation sequencing, to pinpoint the exact defect. That hyper-accuracy is what dictates eligibility for mutation-specific therapies down the line.
Moving right along to Section 2, 5 pillars of treatment. Let's navigate the 2025 multi-therapy ecosystem.
What's absolutely fascinating to me here is how much the treatment paradigm has shifted. We're no longer just throwing basic steroids at the problem. We now have an incredibly sophisticated 5-pillar ecosystem. We've got therapies spanning from epigenetic modulation all the way to advanced RNA drugs that literally force the cellular machinery to skip over the mutated parts of the gene. It's a real game changer.
Now, I know gene therapy gets all the flashy media hype, but I want to highlight vamorolone for a second. It's a quiet revolution that was approved back in 2023. As a dissociative steroid, it gives you the potent anti-inflammatory benefits of classical steroids, but, and this is huge, it markedly reduces the devastating side effects that patients historically had to endure, like severe bone loss, stunted growth, and cataracts.
And then there's Givinostat, approved in 2024 following the Phase 3 EPITUS trial. This was a massive milestone. Why? Because it's the very first non-steroidal drug approved for all mutation types. Instead of trying to fix the gene itself, it blocks those hyperactive HDCA enzymes we talked about earlier. So it directly targets the upstream consequences of dystrophin loss to reduce fibrosis.
Which brings us to Section 3, gene therapy and CRISPR. We're talking breakthroughs, hope, and a bit of controversy.
So the biggest hurdle for gene therapy right now is basically a physics problem. It's known as the packaging problem. The DMD gene's coding sequence is about 11 kilobases long, but the viral vectors, the AAVs we use as microscopic delivery trucks, can only hold about 4.7 kilobases. To get around this, scientists have had to engineer these truncated microdystrophin variants, basically a shortened, partially functional version of the protein.
Now, the drug Elevidys does successfully deliver this microdystrophin, and it gained full FDA approval in 2024. But we have to look at the whole picture impartially here. In 2025, there were really sobering reports of 2 fatal liver failures in treated patients. It's a stark reality check. It really highlights the immense toxicity risks of high-dose AAV vectors, especially for older, heavier patients. But as we know, the science doesn't stop. Looking a bit further ahead, CRISPR gene editing is making serious waves. Specifically, there's a therapy from Huida gene called HG302 that showed preclinical restoration of dystrophin up to 70% using a single-cut Cas12 approach. It is still early days for sure, but it represents the tantalizing hope of a true one-time genetic cure.
Let's pivot to Section 4, the multidisciplinary care base. Because, as you'll see, drugs alone just aren't enough.
You see, despite all these million-dollar molecular miracles we just talked about, survival still relies heavily on rigorous day-to-day medical management. Thanks to major advances in non-invasive ventilation and highly proactive cardiovascular care, life expectancy has remarkably doubled over the last few decades. We've gone from a historical baseline of 19 years in the 1960s up to between 30 and 40 years today in well-resourced centers. Treating this disease literally takes a village. And here's a totally fascinating, often overlooked fact from our sources. The DMD gene actually encodes multiple neural isoforms of dystrophin. When those are missing in the brain, it explains why about a third of patients exhibit cognitive deficits. So, psychological support for things like autism and ADHD is just as critical a pillar of care as preventing scoliosis or monitoring the heart.
Finally, we arrive at Section 5, the future of access, bridging the socioeconomic gap.
Because let's be real, you can't just slap a $3.2 million price tag on a drug and expect it to be a viable global solution. For middle-income countries, take Vietnam for example, accessing these therapies requires some seriously innovative thinking. Solutions range from in-country AAV vector manufacturing to drive down costs, all the way to national newborn screening programs. Catching the disease via CK levels in the first days of life, long before irreversible muscle damage occurs, is absolutely crucial.
So the overarching consensus in 2025, there is no single silver bullet. Instead, the future looks a lot like combining these different therapies. Imagine a gene therapy to provide microdystrophin right alongside givinostat to reduce fibrosis, and vamorolone to safely manage inflammation. This perfectly mirrors the multi-therapy approach that brilliantly transformed HIV from a fatal condition into a manageable chronic disease.
Ultimately, the science has never ever been more promising. We are literally rewriting genetic codes and fundamentally altering the trajectory of a devastating disease. But I'm going to leave you with this. What good is a cure if the people who need it most can't afford it? The true test of this coming decade is going to be answering this profound question of global healthcare equity. How do we ensure these multi-million-dollar breakthroughs reach every single child worldwide? Thank you so much for exploring this fascinating landscape with me today.